The chairpersons aside, Dr. Vimal Nakra and Dr. B.K. Zagari, please.
Now I invite all the panelists and Dr. Pankaj Chaudhary to introduce the panelist.
Okay. So good afternoon, everyone. Because we are tight in schedule, so we just continue our process. So this is a very important subject, how you prescribe nutrition in a different scenarios, right? For example, the patient comes to CKD or CLD, or patient having high blood pressure, what do you do? So this side. So today's panelists are Mrs. Jyoti, and she is the head of dietetics at Max Patparganj. Dr. Satish and Chhabra, everybody knows him, senior nephrologist from Max Patparganj. Dr. Dilip, Bhall, our good friend, colleague for several years with us. Dr. Subhashish, our friend and colleague from Max Specialty, she's a senior gastroenterologist. And Dr. Pradeep Sharma is from Goel Hospital. She is taking care of intensive care. So before we start this panel, I would like to request Mrs. Jyoti to just give a highlight, right? So how you prescribe nutrition, advice to patients who comes in OPD setting. So we'll have some few slides, then we'll start a panel. Mrs. Jyoti.
Thank you so much for inviting me here, and I'm standing here in front of the eminent dignitaries. So what is the role of nutrition in a OPD setup? As Ms. Khosla very rightly explained the role of balanced diet and all, and what we should have, how we should balance, and how we plan out our calories, protein and fats throughout the day. So one thing is that. Another thing is when somebody has a chronic illness, so the first mindset of any patient is, मैं OPD में आ गया हूँ, अब मुझे क्या क्या restriction करना पड़ेगा. So they are so scared when they come to us initially, especially patient with CKD or having a CLD. So what to eat, what not to eat, what all restrictions they have to follow. So we chart out the diet as per their, we assess the nutritional status, which we're going to discuss in the next slide. So how the nutritional counseling helps, it makes them aware with the latest dietary guidelines, what all restrictions they have to follow as per their parameters. And we provide the personalized nutrition plan to each and every patient, so that we see their food habits, we see their cultural involvements, like what kind of food they eat, are they vegetarian, non-vegetarian, they're religious and social foods. So we cover each and everything so that the patient is comfortable what he or she is eating and enjoy that meal. And we guide them to follow the dietary compliance so that they lead a better life. And we monitor, we call them for follow-ups and also that we can monitor their nutritional status and help them following the dietary challenges in every follow-up. So the moment the patient comes in the OPD, the first thing is to assess that patient through the anthropometric assessment, their biomedical parameters we check, and then we follow the guidelines given by the different bodies like IDA, NIN, ICMR, ESPEN, KIDOKI guidelines. So we follow the different guidelines for different disease, and accordingly we plan out the chart. Thank you, and then we will take up with the panel discussion.
So thank you, Ms. Jyoti, for setting a scene, right? So now we have a panel on nephrologist, gastroenterologist, intensivist, right? So we do see a lot of patients who are having comorbidities, right? So I think in Indian setting, right, we are most of the times we are vegetarian, and now comes the protein, right? And in nephrology we say a patient comes to CKD, okay, the protein restrict kar do. So my question to Dr. Bhall, right? So patients of CKD comes to you, right? So what you tell about the protein type, because it's a very, very important subject, right? How you convince the patient that how much protein you should take, because we are all vegetarians most of the time.
So I think that's a very important question. So first of all, we should understand when we talk about a protein restricted diet. Now all these guidelines are unfortunately Western guidelines, where the normal Western diet contains around 3 grams of proteins per day. Whereas an Indian diet and normal Indian diet is around 0.6 to 0.7 grams per kg body weight. So first and foremost, it is very important to look at the patient, understand what his diet like is. There is where the role of Jyoti comes, where we send the patient to Jyoti, she is our dietitian, and she assesses with a dietary recall as to what the patient eats in the morning, afternoon and evening, and then we get some approximate idea as to what is a protein intake per day. Now, before going on to that, we get a basic workup done, look at the LFTs, if the patient is protein replete or protein deficient. Now, if the patient is protein replete, that means the serum albumins are anything more than 3.5 grams. So this patient, and the dietary intake is more than 1 gram per day. This patient should go on to a protein restricted diet. Now the protein restriction, the earlier guidelines said 0.6 grams, but now what has happened is these guidelines have started changing. They've started realizing that 0.6 is not what is to be recommended. What is pushing it is up to 0.8 grams per kg body weight. So it's extremely important to understand what the patient's diet is. If the patient is protein replete, this patient goes on to a 0.6 to 0.8 gram of kg body weight. Now if the patient is protein depleted, now there is no point depleting him further. So this patient has to be given proteins. Now in this kind of a patient, you can go up to 1 to 1.2 grams per kg per day. Now what is the evidence for protein restriction affecting the progression of renal disease? I think we can go back to our historical days when I was doing my DM, that was in the late 90s. We have a landmark trial called the MDRD study, which still holds true today. Now that study has shown very clearly that patients who are protein restricted, the rate of retardation of renal disease is there. So there is evidence and there are guidelines as to go about it, but you have to individualize the patients. That is how I look at my patients.
Right, you mean to say that 0.6 to 0.8 is the gram per kg, is a uniform. But Chhabra, you have the same opinion or you have some different opinion?
I think he is absolutely right. That is what we need, and that's his basic point which he stressed. The first of all is that before even trying to restrict or trying to tell him not to eat or what to eat, ask him what he's eating. And let me tell you, majority of the Indian diets do not contain more than 6.6 to 0.8 per kilogram body weight. So you don't need to restrict him. Of course, there can be a modulation which can occur because you need a higher quantity of class 1 proteins in the patients with renal failure rather than the class 2 proteins. You have to adjust to the calories, you have to give them slightly higher calories because this is a catabolic state. Chronic renal failure is a catabolic state, so they need higher calories, they need good amount of protein rather than restricting everything and bringing them down to zero. You know, the basic thing, how long a patient lives when he goes to dialysis or he goes for a transplant depends upon how good was he maintained nutritionally before he reached there.
So, Mr. Jyoti, right, the patient comes here because we know that PEM, protein energy malnutrition, is very common in CKD patients. So how you go ahead with this and why this PEM occurs in dialysis patient?
Actually, the moment they get to know that, as Dr. Chhabra said, as it is in Indian diet, protein lacks. So when they come, when they get the disease and catabolism starts as it is, and when they reach to us, when we counsel the patient, we see that when we do the 24-hour recall, they are not eating more than 25 to 30 gram protein per day. And as it is, then catabolism starts, so protein breakdown is happening and the amino acid loss is there. So we again, if we don't give enough energy to the patient, say we give around 35 to 40 kilocalories per kg body weight to such patient, so that their proteins are intact. And then they don't go into malnutrition because they're already going to malnutrition by the time they reach to dialysis state in their pre-dialytic
Because we see in CKD patients on dialysis, their patients become very lean and thin and there are a lot of protein losses there. So in that situation, Dr. Bhall, what is your advice, right?
I think the most important thing is that when a patient is prior to dialysis, if he is protein replete, you restrict proteins. Once the patient comes down to dialysis, it's an inflammatory state. So there's excess of breakdown of proteins. Unfortunately, what happens is that more than 70 to 80% of patients continue the protein restricted diet, thinking that probably this is the right diet for them. So we have to emphasize to them that once they are on to dialysis, they can be liberal with the food intake, increase the protein intake. So that's important. We go on to 1 to 1.2 grams per day.
So Jyoti, how you do it? How you increase the protein?
Yeah, that's what I wanted to add on. The thing is, when they come to us, they think we say, okay, you are supposed to have 40 gram protein, 50 gram protein, or 0.8 gram per kg body weight. So they don't know what it is. For them, one katori dal will give them, I don't know how much protein. So in my OPD, I've kept teaspoons. I've kept, small, medium katori size bowls. So I show them, okay, this much dal is going to give you 7 gram protein or 5 gram protein. So we counsel the patient that, if you eat this much, you will get only this much. So then they understand the concept that how much they are supposed to eat. And then we tell them to, eat protein in each meal. So that is important so that they maintain their nutritional status.
Right. I think because most of the crowd here is physicians, right? So every CKD patient is very important, I think. I think the patient should need a dietary counseling, and every patient should be referred to a registered dietitian to go for the protein day, because protein and malnutrition, we see a lot of prevalence of PEM in dialysis patient. So coming back, Dr. Tiwari is there, Dr. Nakra is there, sir. I would like to ask a simple question. When the patient comes to you as a blood pressure patient, hypertension patient in OPD, so what is the advice on salt? Because salt actually is coming in a big way, right? So we have discussed in the morning the salt intake and everything. So how salt is important in patients of hypertension, right?
See, there are two conditions. Patient is already on diuretics, and we have to assess what is the sodium level in the blood. Okay. So we have to restrict the salt to extent that he takes around 4 to 4.5 gram of salt per day, and not more than that, while we are monitoring on the sodium levels and other things and blood pressure. That is about the salt. Potassium, we know that there are certain potassium sparing diuretics and potassium losing diuretics. So we have to make a balance of these combinations. So that is in hypertensive patients we have to maintain the sodium and potassium levels in the blood.
So any guidelines there, Jyoti, that to how much salt that the patient should take in hypertension, the patient who is already having hypertension?
Yeah, as per WHO latest guidelines in 2020, less than 2 grams of sodium to be taken per day, and if we calculate it in a layman language, it's 5 grams. So when any patient comes to me in the OPD, I show them the teaspoon, and on a piece of paper, I divide into 5 this thing. So I tell them, okay, 3 gram is your share. So then they know that much I am supposed to have. So we have to teach each and everyone practically so that they understand. If I simply tell them, okay, eat 5 grams, so they'll say, अच्छा 5 gram, 1 चम्मच हम किस में डालेंगे? So when I guide them, okay, this is for your first meal, second meal, third meal, and in case you missed any meal, so you can add it on to something. So I tell them not to have table salt completely.
Right.
And
Dr. Tiwari, you want to say something?
Generally, my advice to the patient is generally when patient cuts all the extra table salt, still around 2 gram of the salt is available in the diet, not
Absolutely.
salty diet. So if we want to cut the salt or we want to give the salt restricted diet, we tell the patient that you cut all the extra salt or table salt, and that will be the salt restricted diet.
agreed. And another important thing is these days, we are on to ready to eat food, processed foods. That is something. So that is something we have to take care. So whenever we go and buy, MSG is written. So we should not, pick up those stuff and all. And we should see how much content is there. So is it permissible on my daily diet or not? So we have to see very small things and we can live a healthy life.
So why you want to say something?
Ma'am, I have a question for you. Like most of my patients, they are chronic liver disease.
Right.
They have ascites and we are restricting salt. They are already malnourished. And they are already anorexic, not eating. And reducing the salt leads to a decrease in the diet.
So
They get further malnourished. So how do you take care of that? With a low salt diet, make it more palatable.
see, we give them tips like, they can add lemon to the diet. They can, add natural things like amchur in the diet. So it makes the food palatable. So that is very important. As it is, patient is malnourished with CLD and is not eating due to the salt content. So you add the additives, the flavors, even if, you're making something and you put some elaichi or something, tej patta, the moment there is aroma in the food, their appetite increases.
So you have to
Cinnamon they
substitute
can
salt
have.
with certain
We
things.
have the substitute. It's just
Ma'am, the problem we face is any kind of liver disease in our country, the neighbors, the family
Exactly.
Everybody becomes a dietitian.
Absolutely.
They tell them no fat, no oil, no salt. You should take only boiled food. Now, if you reduce the salt here, they don't eat anything.
Yeah.
And already their primary disease makes them anorexic.
Absolutely.
Their metabolism, absorption, everything is hampered.
Right.
So that is a major issue I face with my patients, especially those who are diabetic. No sugar, no salt, and the family has already restricted fat.
So,
They are only on boiled vegetables.
So patient with
For
diabetes with CKD and CLD, what to eat, what to eat then?
So for CLD patients, when they come to us, we take a basic thumb rule of calories. You have to take complex carbohydrate between 50 to 60 gram depending on the patient's weight. If the patient, like, in India, we are seeing the trend of obesity, and obese patients are also developing CLD. So what we do is for such patients, so we tell them, okay, you have the complex carbs, your protein comes first, so maybe around 30 gram protein we plan, 25 to 30 gram for such patient. Rest of the calories will come from fat. So it's not that they will have a boiled food. Fat is very important for your fat soluble vitamin A, D, E, K, and you know how much vitamin K is important for CLD. So you have to counsel the patient. It's just not that the boiled food or a salt-free food, how they can make the food palatable and interesting. Like, like CKD patient, they said, ma'am, dahi bada khane ka man karta hai, but dal is restricted. I said, okay, if you want to have a dahi bada, suppose in the lunch you have a bowl of curd, you take dal and make vada. When you soak it for a longer time in the water, or you boil, the oil goes, and then you squeeze and have it. That is your dal and dahi combination. So how you counsel the patient, how you teach the patient so that they can enjoy with their chronic diseases. When they come to us at time, they go to our doctors and they say, dietitian ne अच्छे से समझाया था. So that is the, a trophy to me when they go happy from my room.
So, just want to say, add something.
At times in our clinic, the patient comes, we explain them the diet and everything. Still he feels, is there any supplement which we can take, which contains everything and a balanced thing in the supplement, rather than going in for calculating all this complex jugglery?
Sir,
This much is protein, this much is sugar, this much is like that. Is there any supplement? Although she has said there's no supplement.
So there are supplements if patient is not eating well at all, and then I give them a food holiday also, so that they start eating. If a CKD patient is having diabetes also, so if they ask, can I have an ice cream once in a while? And when they are nauseatic and all, and they are vomiting badly, so I tell them, okay, you have ice cream. So we have sugar-free ice cream available to us. To start that patient to eat to that level, I give them a food holiday, so that they can start eating. And the supplementation, we do have supplement where we can meet up the, for a balanced diet, I also don't recommend supplement. Eat a normal diet. You have everything on your platter, the way she explained. But yeah, when it's a disease condition, patient is on a hypercatabolic state, patient is not eating anything, then we do administer supplement like CLD and all. We have peptide-based formulas where they are enriched with MCT oils. So when they have, so they can meet up their micronutrients, and macro we can, then later provide through the balanced diet.
So Dr. Subhashish,
just a moment. There are you obviously you're flabbergasted by a lot of market powders. People come back and say, sir, this is a powder for chronic renal failure, this is a powder for dialysis patient, but all these are not really going to help you that way. It's basically the food and the quantity, like the first madam showed you, the thali is what is going to matter. How do you really make that thali palatable? What Jyoti suggested, and Jyoti has been doing that, is what is going to be the most important thing. But when you are really stuck, somebody who says, I am now going to eat something, so then you go for the powders. And there are powders available for each particular condition.
Dr. Praveen is sitting for some time. So Dr. Praveen, you are managing a lot of ICU patients, critical care patients, and we all know that they are all in catabolic phase, and nutrition is very important. So there are a lot of supplements that come up. Like we have seen that a lot of trials have been done in some glutamine or glutathione, arginine. What is your take on that? Because it's a very confusing issues at times. Whether we should give or whether we should not give.
Sir, it's basically nutrition. It's a immunonutrition, nutrition beyond energy. So the supplements that they are in available are glutamine, arginine, omega-3 fatty acids, antioxidants, and to some extent probiotics also. But what this is the what the theory as the glutamine is important for glutathione synthetase, and that's a for nucleotide, and then for proliferating cells. So it prevents the translocation of bacteria through the gut, so to prevent the bacteremia. And the second, and it increase for the lymphocyte synthesis also. But what the evidence is, only Canadian guidelines says it has to be given for mechanical ventilated patients who are on burns and trauma. Even SPEN or the American Society, ma'am has mentioned, they say state no. Only, and then European guidelines says only enteral is, no use of IV.
Right.
And then, but there is a one major redox trial, it was in 2013, New England Journal, and they have included 40 ICUs across US, Canada and Europe. What they found, the target is 28 days mortality, and there was no change in the mortality. In glutathione, antioxidants, these groups they had taken. But what one subgroup, that finding was very much important in renal disease patients. The mortality was more. So one should be very particular about, one should not give glutamine in renal disease patients in ICU.
Right.
And then the other one is arginine, no role. It is basically having a vasodilator properties, and the most common shock in the ICU is a septic shock, distributic shock. Then again, omega-3 fatty acids basically decreases the pulmonary neutrophils. So it has got role in mechanical ventilated patients in ARDS. That is what Canadian guidelines. Other guidelines says has no role for it. Then probiotics, mainly hospital-acquired pneumonia, and then antioxidants you may give.
So I think very important message you have given, the judicial use of this all supplements. Lot of this nutraceutical supplements have been available, like ketonologues and all that. So what is the role of this? Because this is a lot of pharma company coming up, write this to our patients, and you will see a benefit. So what is your take on this, Dr. Chhabra and Dr. Bhall?
Yeah. So I think now we always face this problem that patient always asks for patient, what is the drug for kidney failure? So because you are giving anti-diabetic, anti-hypertensive, things like, so we have basically ketonologues and probiotics. So there is some data on ketonologues, right? So the data says that once the patient reaches stage 4, stage 3 or late stage 4, ketonologues given to a very low protein diet. Now a very low protein diet means 0.3 to 0.4 grams along with 1 tablet of ketonologue per 10 kgs of body weight. That means 60 grams, 60 kilos means 6 tablets.
6 tablets.
There is some data that there is some retardation. So 2 good studies, one by the MDRD and the other given, there's a Romanian lady by name Liliata Garnett. She has shown that there is some retardation of progression of renal disease, but the number needed to treat is more than 20. So it will be very careful when you use this, right? Secondly, probiotics, anti-inflammatory, but no clear-cut data on retardation of renal disease. There is some data about this.
Subhashish, your take on probiotics?
So probiotics are only proven to have some role in some of the liver diseases like acute or chronic liver failure, acute alcoholic hepatitis, and where now more and more role of FMT or fecal microbiota transplant is coming up. And even in chronic liver disease, some studies have shown, but these results are equivocal. I have just one comment on this food supplement. Like many of our pharmacies, the pharmaceuticals are coming with GI specific food supplements for chronic liver disease, which have branch and amino. We need to increase the protein intake for our patients to 1.2 to 1.5 gram per kg. But when we actually look at these supplements which have branch and amino acids, the protein content goes down to just 15-16%. So actually the cost increases and the amount of protein we are giving is less. So one has to choose these supplements very carefully. We may be adding some BCAAs, but reducing the total amount of protein there.
We see a lot of BCAAs in every prescription of a patient who is having CLD. So I think this is a myth actually. The fact would be rather that we have to very judiciously use of these particular supplements. And the first lecturer also said that supplements are not, exchange of what the patient actually taking. Jyoti, your comment on this?
Yeah, I wanted to, it's mentioned for branch chain amino acids. So what we tell the patient is to go on a vegetarian sources of protein. So the moment they start having that and, leave the animal protein, so we see how much they are eating. So we tell them to have paneer and pulses and, add sprouts in your diet. And I tell my patients to even make atta with milk. So that how we can, reach up to that grammage of protein that patient is supposed to have. So there are ways to counsel and there are ways to add in the diet, but yes, when they're not eating, only then we advise them to have supplements.
Right. So I think with this, I think we can stop here because there are a lot of queries and questions that we can during the dinner time or whatsoever. So I think one question from the audience is,
I was in ADA recently, and the lecture on Finrinon, the nephrologist said he would not restrict the fruits for his renal patients. Your take on it?
Okay, so Finrinon is basically a MRA.
No, I'm not talking about Finrinon. I'm saying he said that he would not restrict the fruits in a CKD patient, including potassium-containing fruits. This is a comment he made, and he gave a science behind it. What is your comment on it?
See, that I think is an individual comment.
No.
No, okay, I'm coming to it. You're talking about potassium. Yeah. So, okay, basically. So what we'll do is, again, I would look at his, the stage he's in, the additional drugs that he's taking. If he's on ERBs, he's on Valsartan, so he's on MRA, or if he's taking Vimada, or if he's going to take MRAs, and his potassium is reaching 5. So definitely I would like to restrict. But if he's not on these doses, and his potassiums are okay between 4 and 5, maybe I'll not restrict fruits, right? So I would like to individualize, right?
So I think with a lovely discussion, and the take home would be that, in chronic illness like CKD, CLD or hypertension, I think it's basically what you have to alter your food habits rather to have supplements. So there are a lot of pharmacy gimmick, a lot of supplements available with us, but I think they are not being replaced by the food that we are taking, and I think we can always challenge to that at times.
I want to say patient want to eat, not the supplement.
Right. So with this, I thank our panelists and chairpersons for this lovely session. Thank you.
Yeah. I request Dr. Rajiv Gupta to please give moment to.
The next topic for the day is role of nutrition and pharmaceuticals in prevention of cardiovascular diseases, the emerging concepts. And I would request Dr. J.P. Sahani, who is the speaker, to take stage. And I request Dr. Rajiv Pase, Dr. R.P.S. Makkar, Dr. Ashok Kumar, and Dr. N.P. Singh to come onto the stage to chair the session.